Good afternoon, everyone. Welcome to the 10th session of Foundation course in Palliative Care. Today, we are going to discuss about the topic Advanced Care Planning. We have our faculty, Dr. Roop Gursahani, and our facilitator, Dr. Deepa. So, for the faculty presentation, I welcome Dr. Deepa.
Thank you, Sangeet. A very good afternoon to one and all joining us today. I can see many familiar faces. So, welcome to everyone. Today, we have a very esteemed faculty with us, Dr. Roop Gursahani. Probably many of you already know him. He's no stranger to the world of palliative care. He's a consultant neurologist working out of the Hinduja Hospital in Mumbai, a very prominent advocate for palliative care in the country. He's worked in various settings across Mumbai, consulting for patients across the country as well as abroad. He is a founder trustee of the Forum of Indian Neurology Education. Also, recently, last year onwards, sir has been instrumental in formulating the neuropalliative course with the International Society of Neuropalliative Society, with the International Neuropalliative Society. So, Roop sir, a warm welcome to you as well. We understand you are traveling and still you have been grateful enough to take this very important session on advanced care planning. Over to you, sir. Sir, you're muted, sir. If you could.
Oh, right.
Right, sir.
Right. So, have you got my presentation?
Yes, sir. We have got your presentation. We are just opening it, sir. Just a minute.
Okay. Yeah. So, I'm going to turn the video off to save my battery. I'm actually
Sure,
in Goa, but it's raining very heavily and the power is gone. Otherwise, I'm fairly comfortable.
Right, sir. Here also, actually, there have been heavy rains since morning. There are traffic jams.
Yeah.
A lot of things going on here also. I think it's part of the same storm in over there and here.
Yeah. Okay.
Just
So,
give me a moment, sir. I'll load your slide.
Yeah. I'm just turning my video off.
Sure, sir. Because of the rain since morning, we have been facing some technical glitches here and there. I
Okay.
hope that during the session it won't become much of an issue.
I hope so. Perfect. That's it.
Full screen.
Yeah. Right. So, hi everyone. My name is Roop Gursahani. I'm a neurologist, as you've been told. And towards the end, I'll probably see if I can explain how I got uh, involved in something that is actually a much more general responsibility. It's important for neurologists, but it is a general responsibility, and all of us need to be aware of it. Next slide, please. You'll have to advance the slides. Yeah, right. So for those of you who may be able to read Hindi, this says that life and death have life and death have become very expensive. Nobody is born without a cesarean, and nobody dies without a ventilator. Next slide. And yet, you have this situation from across the world, from elsewhere in the world, and there is this Twitter uh, message that I got about somebody whose grandfather passed away, and the night before he passed on, he could actually enjoy a beer with his sons. Next slide. So in some ways, we are ahead of the rest of the world in digital finance, not really far behind in communication and medical technology. But we are 4 decades behind in how we manage death and dying. Why is that so? But I'm still optimistic about the future, and some of this is stuff that we need to do to make this happen. Next slide. So if you think of it, think of any trip. Would you like to plan it? Would you want information on travel, stay, etc.? Now, once upon a time, I could jump into a bus, go wherever I wanted, not worry too much about what I was going to eat and what the restrooms were like along the way, not even worry about where I would stay. But that, as I have gotten older, is no longer acceptable. Next slide. So think of the last journey of your life. The destination is fixed. And the question really becomes, what do you want your experience of your last illness to be like? Next slide. On the flip side, you have this situation in India. Some of you have seen this news clip where a elderly Mumbai couple actually wrote to the president saying that, give us euthanasia, we have no one to take care of. Of course, that's a kind of an indictment of our social systems, that people actually have to think this way. Next slide. But what it really meant was that this couple wanted the president to send a helicopter to evacuate them to heaven. I don't think that is a realistic expectation anywhere in the world. Next slide. And this is especially true, this responsibility is especially true for those of us who are without immediate family and are dependent on friends or acquaintances and so on. And as time goes on, more and more people are going to be living alone. Next slide. Now, the thing is, when we are asked, and this is something that has been documented across the world, 90% of us want to die at home in our own bed, but in reality, 70 to 80% actually die in hospital. Next slide. So to prevent that from happening, you have a document and a system, and that is what we are going to be speaking about. Next slide. And it is not as though this is not a routine thing. Elsewhere in the world, it is so routine that it is literally advertised all over the place. It's part of public health communication. So this comes from a bus in the UK. If tomorrow everything changes, leave no doubt. Unfortunately, we have not yet there in India. Next slide. It's important for all of us to understand how we die, because it's not until we do that do we know how to make sense out of all of this. Now, if you ask anybody, everybody's hope is for a sudden death. You go to bed one night and next morning you wake up in heaven. Next slide. Unfortunately, you have to realize that most people who die suddenly, and actually that's a very small number, typically do so under the age of 50. These are people who lead risky lives, soldiers, terrorists, people who smoke too much, people who drive motorcycles without helmets. But after the age of 50 years, only about 7% of people die suddenly. And you have to have a lot of punya to have the kind of death that our long-haired president, Abul Kalam, got. Next slide. For most people, you have these following illness trajectories. The first one that most people are aware of is cancer, but it only accounts for a little under 20% of deaths. And this tends to peak in people in their 60s. In cancer, people are in fairly good functional status until, say, for instance, the second chemotherapy fails, or at some point the tumor just goes out of control and that is an inflection point after which you can literally state the trajectory. And we call that a waterfall trajectory because we are fairly good at predicting when it will end. As I said, it accounts for only about 20% of all deaths. And those of you who recognize this picture, this was our former defense minister and Goa's chief minister, who was literally at his desk 1 week before he passed away. Next slide. For people in their 70s who have organ failures, bad diabetes, blood pressure, causing kidney, heart, lung, liver failure, this accounts for about 15 to 17% of individuals. And they come into their illness with a somewhat poor level of function. And after that, they go into what is called a looping or a entry-re-entry trajectory, where they decline, end up in hospital, come out not as well as before, then again decline, again crisis, again recovery, until eventually they pass away in a crisis. Next slide. As people age further into their 80s and 90s, and obviously if they pass through the cancer and the organ failure bit, then they end up with what is called a dwindling trajectory. Here, people enter their 80s at a low level of function and keep declining until eventually they pass away after a variable period of time. And this is called the frailty and dementia or dwindling trajectory. And that accounts for almost 50% of us. Next slide. There is one more trajectory which is now becoming apparent, and that is the trajectory of neurocritical illness. This is somebody who otherwise in previous years would have died suddenly, but now is rescued by intensive care, but ends up with significant brain damage. Some of them, of course, die after a period of time in the hospital or ICU, but some remain in the persistent vegetative state, and some improve with significant disability. This is a small number, but it actually causes a fairly huge burden on families and the systems. Next slide. So I guess you will have understood this by now. For about 85 to 90% of us, death is actually predictable, some weeks or months before it occurs. Next slide. And yet there are problems. These problems actually are very prominent in India. The first is that we are not willing to talk about death. This loses us the opportunity for last wishes. It also loses the opportunity for something called life review, which is an emotional settling of accounts. And this is probably one of the most important things that people quote towards the end of life. From a legal system, our laws really do not permit patients and families to take control, though that is now changing. Doctors are scared of making decisions. Legal system is worried about misuse. And the default option is to continue till the bitter end. And then we have poor access to palliative care. Till a little while ago, morphine for physical pain. Even now, it's not very easy to get everywhere. And how do you address problems beyond physical pain, spiritual pain, psychological pain? Palliative care is a small specialty, just about 200. And that's one of the reasons why we want all of you to learn and be able to help your patients with this. Next slide. So let's come back to our question. Think of the last journey of your life. Who has the information, who is planning, and whose responsibility is it to plan? Next slide. Now remember that if you think of it, foreseeing and foretelling was always the doctor's responsibility. Next slide. I am a doctor. Patients do expect us to prognosticate, and prognostication is not just foreseeing, it is also foretelling. And they expect us to do this honestly, accurately, and optimistically. Unfortunately, this can be a difficult triad. Next slide. Usko mat batao, don't tell him, don't tell her, is actually rubbish that we allow because we doctors are not trained in the skill of delivering bad news. And patients, family, community need to understand honesty really is the best policy, because depression and anxiety worsen with concealment and collusion. But of course, here we are speaking of something before that. Next slide. So till we reach the stage that doctors are willing to tell and patients are willing to hear. Next slide. Effectively, the medical policy is don't ask and don't tell. If you're a patient, the ball is really in your court. Next slide. So come back to the question, who is planning your last journey? Next slide. Is it you? Next. Someone you trust? Next. Or the default mode, which means that nobody plans. Next. If there is nobody willing or able to make decisions, then you get the worst suffering. Because to minimize suffering, to use palliative care, somebody has to make decisions. Next slide. Ideally, if you can speak coherently, you decide. And your choices and decisions always come first. Next. Next slide. Yeah. Well, the problem is that once the dying process begins, people lose that capacity. And in cancer, this will happen days, maybe weeks before death. In organ failure, as you can imagine, as people get encephalopathic and confused, this tends to fluctuate and can be days, weeks, months. But the worst problem is actually in neurology. For instance, with dementia, this can be as long as a decade before death. Next slide. So you have to then take up the question of autonomy. Autonomy is saying that I have the right to determine my own future, to accept or decline any therapy, to decide who decides for me. Now, as an absolute concept, it's probably Western. In India and in other Asian societies, we prefer to think of it as in terms of relational autonomy. One Sanskritic term is swadharma. This means that your autonomy is yours, but it is exercised in consultation jointly with the people closest to you. Next slide. But at least some decisions you do have to make. Do I decide? Or do I decide who decides? Because as I said, if you do not take part in any discussion or decision making, then you get suffering by default. Next slide. If you look at people, and this is true across the world, and ask them what role they see for themselves, I personally think about, and this is something that will vary from demographic to demographic, I personally think about 2/3, maybe a little more of people would say, I decide. Some of them may be autonomous because they take responsibility themselves. Some may be altruists, they don't want to trouble anybody else. Next slide. But about 1/3 of people would say, let others decide. And here they may either transfer their authority by explicit authorization or implicitly, just by saying that I trust my family to do what is right. There's only a tiny minority of people who says, I do not want to talk about this. God will decide. Next slide. So anybody who's taking on at least part of the responsibility, the first part of the responsibility is to decide who decides for you when you cannot. And it's understood worldwide that you must try and have 3 people who can accept this responsibility and are available when needed to exercise that responsibility. You put them in sequence. The first, the second, and the third decision maker. Basically, if the first is not available, then the second comes in. If the second is not available, the third. In Indian families, you'd expect all 3 to be present, but this is not a committee. Because actually speaking, only one person has to decide. Next slide. The next decision is the location of care. If it is acute care, then typically it means the intensive care. And no intensivist I know would want to die in an ICU. Lights are on constantly, there's continuous noise, and there are strange masked young people who do painful things to you and maybe even make jokes while they're doing it. We've all Any one of us who's been a resident knows that. Next slide. But why would you want to go to a hospital or an ICU? You want to go there only if you want life-saving treatments. And the first and a very important concept to understand is that you have the right to refuse any or all of them. These include cardiopulmonary resuscitation, ventilation, even IV fluids and antibiotics, artificial tube feeding, dialysis, chemotherapy, obviously you can understand. You have the right to refuse any or all of them. Why? This is because in many patients, they do save lives, but in many others, they only prolong the dying process. Next slide. But if you do decide to go to the hospital, can you avoid the ICU? Yes, you can. You can say, I will stay in the hospital ward because my family cannot manage at home. We will not go to the ICU at all. Of course, assisted living and hospices are facilities that are available elsewhere. Unfortunately, India, hospice is available only for cancer. Worldwide, as I said earlier, the overwhelming majority would prefer it to be at home, to pass away at home. Next slide. Is it possible to pass away comfortably at home? Yeah. So these are pictures from the two Bushes who passed away in 2018. You heard about Jimmy Carter, the oldest surviving US president. He's at home. He's in hospice care. He has decided he will not again go to hospital. Next slide. Is it possible in India? Well, maybe not so in the big cities, but definitely possible in rural Kerala. Because hospice palliative care at home is the norm there. Next slide. When we begin to talk about these issues to our patients, you have to understand that this communication falls into three categories. These overlap, but it's important, but they are part of the same end of life communication. The first is goals of care. This is basically patient education about that particular illness and what is possible in that particular patient at that time. So it's a repeated conversation with patient and family. And it is a departure from the usual approach of talking about treatments. It is finally an individual clinician's responsibility. On the other side is the process that is termed advanced care planning. Here, somebody can plan or to receive or not receive different types of treatments in the future. But this is part of public policy. It has documented outcomes and needs a system and infrastructure to carry it out. The last is called shared decision making, which happens right towards the end as the crisis hits or the person is in the ICU or the hospital. Next slide. So advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. For many people, this includes choosing and preparing another trusted person to make medical decisions for them. And when we speak to the other persons concerned, we ask them to think of becoming your loved one's voice. It's more appealing to the patient because it implies both advocacy and understanding. And for the proxy, they then understand that they are just channeling their loved one's wishes rather than making decisions themselves. And the goal is to help ensure that individuals receive medical care that is consistent with their values and preferences during serious and chronic illness. Next slide. Yeah. So there are various terms that we use. We've spoken about ACP. Healthcare power of attorney is a legal document that appoints an agent to make future medical decisions, which becomes effective only when the patient becomes incapacitated. A surrogate decision maker, on the contrary, is a decision maker who's brought into the picture when the patient is incapacitated without previously identifying healthcare proxy. And you need a hierarchy to identify the surrogate decision maker. In India, the only one that we have is from the All India Institute of Medical Sciences end of life policy. Next slide. Advanced Medical Directive is a legal document that describes preferences, appoints a surrogate or proxy, and is valid legally. Next slide. Sorry, just go back, please. Just go back. Yeah, the living will actually documents an individual's wishes prospectively regarding initiating, withholding, withdrawing various kinds of treatments. And again, as I said, it becomes operative when the patient cannot communicate. But at the end, you have orders for life-sustaining treatment. This also includes do not attempt resuscitation orders. These are medical orders that translates these preferences into orders, and they have to be countersigned by a doctor so that other doctors will accept them, and they are intended for serious illnesses and can be transported across healthcare settings. So depending on whichever hospital you go to, this document should be valid everywhere. Unlike advanced medical directive, which is in that sense more general. It just speaks about wishes. It doesn't actually say, now don't do this, and so on. Next slide, and I'll show you how that works. Yeah. So now the healthcare power of attorney basically makes healthcare decisions when the patient lacks decision-making capacity. Sometimes they may have limited discretion, meaning their only responsibility may be to see that the patient's wishes are followed. But usually we prefer them to have discretionary options because the living will cannot cover every option. It cannot cover all the various situations that may occur. And if somebody accepts this responsibility, then they should be aware of the patient's wishes, and they should have a copy of the documents, and they should have ideally have confirmed their readiness to serve as decision maker. Now, we've already explained what is the difference between the proxy and the surrogate. Next slide. So the living will varies. Different jurisdictions, especially in America, have different contents that they accept. But it should address CPR, life support, hospitalization or not, pain control or not, tube feeding, and so on. Unfortunately, the options that you can actually list down are finely limited. You cannot write everything possible. And that's why the clinical decision making at the end really requires a human who understands all of this to discuss with the doctors. Next slide. Which is why most jurisdictions now prefer a combined advanced medical directive, which combines both. And multiple options are available. There are the best known across the world is called 5 Wishes, and you can actually download it. I've shown you a sample of the document that we have prepared, and I'll show it to you again. Next slide. Yeah, so this is it. This is the document that you will see on the Pallium India website. This has been prepared, and this is supported by it's also there on the Indian Association of Palliative Care website. This is the one prepared by our group. As of now, this is the one that we are recommending. Next slide. And you can see it specifies the situations under which it becomes operative. In addition, it requires that this has to be confirmed by a panel of 3 doctors. And if that is so, then at that stage, well, this document says which treatments should be carried and which should not be carried out or even removed if they are started. Next slide. It also puts down a list of 3 names with their details and their signatures so that they have confirmed that they are accepted. Next slide. And it remains in force until it is revoked. It has place for signature, and it is supposed to be countersigned by 2 witnesses and either a gazetted officer or a notary. Next slide. As I said earlier, if you search for this document, write Living Will and Pallium India, you will get it. Or Living Will and IAPC or Vidhi, you will get it. Next slide. So we've already spoken about end-of-life communication. You will understand, you have begun to understand how this works. Next slide. I think these slides are repeated. Just go through this. Maybe I'll go on, go on, go on, go on, go on, go on, go on. Yeah. Okay. So when you need to talk about this, how do you have it? How do you have an ACP conversation? Next slide. The first step is to initiate. And actually, anybody can initiate this discussion. This does not require doctors, nurses, social workers. In fact, in some areas, trained facilitators can do this. So this has to be done as a routine part of care. Of course, it can be triggered by a clinical scenario. You have to start by assessing the patient's current knowledge of this whole bit. So I always ask them, have you heard about a living will? Have you actually prepared it? If they have it, can you tell me what it says? And in fact, you have to actually look at it. Next slide. You have to normalize this conversation. So what I say is I encourage all my patients to think about planning for the future. There is no right or wrong answer here. It's just important that we know what your wishes are so that we can follow your goals. And you'll be surprised. Even patients who have begun to the process of dementia can understand this much. Next slide. Then you explain how these documents are used, the benefits, the limitations. Ask them if they have somebody who they would want to speak for them, and educate them about where to get these documents. Ideally, they have to download and make these own documents themselves. Next slide. Go back. One point that you have to tell them is that this must include their loved ones. Their wishes have to be shared with the people whom they are appointing as proxies. Next slide. One of the problems here is that people have seen TV shows where somebody gets CPR and 1 minute later or in the next set is actually getting up and walking out of hospitals. I hope all of us here understand how unreal that is. It's only if patients are in decent condition and if the arrest happens where effective medical care can be used that you get a 30 to 40% result. Very often, it is much less than that. People who get CPR outside the field survive only about 10% of times. And if somebody is dying, which means they are seriously ill, then CPR works less than 5% of times. So how you frame the discussion matters. And one thing is that if they have to actively choose invasive or aggressive care, then they think about it differently. And you have to work to understand the patient's values and so on. Next slide. Now, this requires an input from the patient and the family, together with the clinician, and it may occur over a few visits because they may need time to discuss it with their family. And it's good for them to use the various available resources before they make their mind up. Next slide. Values are of various kinds. They're in relation to life, death, dependence, dignity. Some of these are rational, or some of these are just a sense of awareness of what you would like and not. People have various ideas about autonomy. In non-Western cultures, as I said, relational autonomy is more important. Attitudes towards health vary. Sometimes this is decided by religious background, but typically I have found religion is an excuse. When somebody doesn't want to make a decision, they'll say, God will decide. And obviously, what is the kind of social background, the finances are also important. Next slide. Once you've done this, the fact that you had this discussion should be included in your medical notes, and the completion should be documented. The document should go into the record, and copies should be available to all relevant family members. Next slide. unless the patient says they don't want to. And then you close this meeting. It may take over a period of time, something like 15-20 minutes, and some patients may take even longer. And you have to tell them that, one, that we understand that this is a lot to process, but you're brave to have talked about these things and offer your support. I'll be with you every step of the way. Now, these documents, especially in people who are ill or elderly, must be rechecked. Sorry, somebody needs to mute, please. Hello?
Yes, sir, we have done that, sir.
Yeah. So in older people with illnesses, we recheck every year. Otherwise, generally once in 5 years. And in Western countries, it's now part of the well elderly schemes that they have in various places. Next slide. Now, challenges are, one challenge is that we are always waiting for the right time to do this. And I'll show you how that is wrong. We do not clarify patient preferences. We ignore patients who are communication impaired. And if there is already an advance directive, we assume what it is saying. Next slide. We have to actually read it and see what it says. Patients, family members all have this question. What if I change my mind? Next slide. The important thing to understand is that these documents can be revoked instantly orally. To make them, they have to be made in writing. And obviously, it's a complicated process. But if you are awake, able to speak, even if you're confused, even if you're obviously delirious, and if the doctor asks you, this is your living will, do you want to follow this? And you say no, it is revoked instantly. So that is a basic precaution that we all have to take when we actually start implementing them. Next slide. But how to do it? Remember, it always is a conversation between the patient, the family, healthcare providers, and ideally, you need facilitators or counselors who are trained for this role. It's not necessary that doctors have to do it. All of this has to go in the medical record, and we need a system that confirms that this is acted upon. Next slide. When to do it? Well, ideally, as I said, anytime. But if somebody has a new diagnosis of a serious illness or is hospitalized, especially after the age of 80, or starts requiring more and more care, somebody who's completely independent, was going out for a walk on their own, managing their own accounts, stops doing all of this. That's when this has to be done. But whenever it is done, it always seems too soon until it is too late. This is true of the estate will for property, and this is true of the living will. Always seems too soon until it is too late. Next slide. So basically, you need to do it anytime. Now, anytime, next slide. Would you do it, say, if somebody is, say, in their 20s, 30s, absolutely hale and hearty? Yeah, if that individual is worried about catastrophic brain injury, if that is an individual who's clear that they may want to donate their organs and so on, then this is a conversation that they need to actually go and have. Next slide. So if you look at these two pictures, look at Barack Obama, and everybody knows Michael Schumacher, right? Barack Obama, before his first presidency ended, he had actually made an announcement that he and Michelle had made their living wills. Now, at that stage, he had not even crossed 50. Why would a young man do that? He did it because, well, the US president has an occupational hazard of being shot in the head. What about Michael Schumacher? Next slide. His racing career, he made something like $600-700 million over that period of time. Retired, and then he had that skiing accident, very literally just somersaulted and cracked his skull. And well, as far as we know, he's completely dependent even at this stage. This was 10 years ago. You think he would never have discussed this during his Racing days? Don't know. Next slide. Now, as people cross into their 50s, 60s, if any major illness gets diagnosed, it's obviously not minor things, but yes, if somebody's creatinine crosses 1.5, if somebody has diagnosed COPD, or so on, or if somebody has a diagnosis of malignancy, even though it is treatable. Next slide. And I would say that after the age of 60 years, with any new diagnosis. Next slide. So, this was a patient of mine who had a recent diagnosis of hypertension, was started on medications which she was non-compliant, and then she got admitted with this massive brain hemorrhage. Now this brain hemorrhage left her completely paralyzed on the left, but she was able to feed herself and control her urine and motion and speak. She was actually saved because she underwent a surgery called a decompressive craniectomy. That's quite a massive surgery, but she got saved. And when she woke up and she was okay, she did not like it at all. And unfortunately, her poor husband, who was a dedicated caregiver, actually just could not take the fact that she was not happy with his decision. Next slide. If she had a living will, her wishes would have been followed. Next slide. But going through this, eventually people reach a stage where you can make a judgment that they have an expected survival of 1 year or less. And when you reach that, then the documentation changes significantly. Next slide. So the documentation here is called physician's orders for life-sustaining treatment. Now, as opposed to the living will, which is signed by the patient and witnesses, the physician's orders are signed by a physician and the patient or patient's proxy. It specifically covers CPR or not, level of medical interventions that are wanted, including artificially administered nutrition, which means even a rice tube can be covered by this. Next slide. And they are made on distinctive bright paper. Multiple copies are made available. In the US, typically, one copy is put up on the fridge under a magnet, so that if the person is found unconscious, then anybody who is called by in the emergency can see it and decide what the patient had wanted. As opposed to a living will. A living will is impossible for you cannot read it in an emergency and make decisions. Ideally, you need medical orders. Next slide. So these are the documents, and you can see the first is attempt CPR or do not attempt CPR. The next is if the patient has a pulse and is breathing, comfort measures only, which means you may not even shift to hospital. Limited treatment, if you remember what I had told, go to hospital but not go to ICU. Or last is full treatment. And any one of these ticked. Next slide. Next slide, sorry, again, this is duplicated. Go on. Yeah, this is it. If you want to see these in detail, these are available from this website. Next slide. Unfortunately, in India, these are still not regularly used or valid. What do we have? We have the ICMR DNAR document. This is instrument that was prepared by a group of which I was a part. Next slide. And next slide. And you can see that this has a form. Go back. Yeah. And you can see this has a form which any institution, any practitioner can use. It's from the ICMR. So it's as good as legally validated. And it has an algorithm which you can look at if you need any kind of assistance in how to follow this. So you understand that the living will and the advanced medical directive, take you up to a certain stage, but for the final stage, you will require this document. Of course, the living will that we have prepared for India, we actually go till the last point also, because at that stage, this document had not been prepared and we wanted to make sure that we are as complete as possible. But I would recommend that anybody using that should ideally, if possible, make this as well, because this is countersigned by a doctor and should be followed by any doctor who sees it. Next slide. So I have been involved with the situation since 2011. I was part of the Aruna Shanbag court case. Next slide. Next slide. And but it was some time after that that the realization dawned on me. This was around about 2015. I was part of a meeting where I actually made this statement. Like everyone else, I will die someday. I want my dying to be as much under my control as possible, and I want to do it right. And I do not want the laws of my country to stand in my way, because at that time we had nothing. Next slide. Over the next couple of years, 3 national medical associations came together, the neurologists, the intensivists, and the palliative care physicians. Next slide. But we were also lucky that we were able to get legal support. The person who came with us first was this gentleman, Advocate Girish Gokhale. Unfortunately, he has passed on. But then Dr. Dhvani Mehta of Vidhi and Senior Supreme Court Advocate Arvind Datar both helped take us over the finishing line. Next slide. And we were lucky that the Supreme Court of India had decided to carry the liberty of the Constitution of India into the 21st century. And if you realize, there were 3 judgments that came out almost within about a year of each other. The first was the privacy judgment. The second was health autonomy. But the third was the sexual choice judgment. And if you see, they all seem to follow a certain basic principle. Next slide. It was only the health autonomy judgment that had a lot of restrictions as to what you could and how you could carry it out. Finally, on the 24th of January 23, this year, the Supreme Court lifted those restrictions in a new order. And we know that now we are at the end of the beginning, but there's a lot that still needs to be done. Next slide. It's important to understand that in these judgments, the principle that has been enunciated is that all adults with the capacity to consent have the right of self-determination and autonomy. A competent person who has come of age has the right to refuse specific treatment, all treatment, opt for an alternative treatment, even if this decision entails a risk of death. We can treat in an emergency only when it is not practical to obtain the patient's consent. But where a patient has already made a valid advance medical directive, which is free from reasonable doubt and specifying that he or she does not wish to be treated, this directive has to be given effect to. This is the law of the land. And any doctor who says, no, I will not follow this instruction, is liable to be, well, there's no prosecution, but these are actionable. And in the US, the maximum litigation is actually to do with what is called wrongful life. Here in India, we are worried about what will happen, which relative will come from the US and say, what did you do? You killed my mother, and so on. Worldwide, that is not the experience. It's actually the other way around. When people are resuscitated against their wishes, the family sues. Next slide. So just to reiterate a couple of points, the AMD in India becomes valid with 2 witnesses and after attestation by a notary public or gazetted government officer. Elsewhere, it takes, these are often not required, but in India, this much is required, and I think this is a major step forward, and we need to carry it out. Next step. Next slide, sorry. But for it to actually work, we all have to start talking. patients, families, doctors, paramedics, everybody who's involved. We all need to talk. One important thing to understand is that uh, advanced medical directives, advanced care planning is like, in some ways, like vaccination. If you remember, once upon a time, vaccination was nobody's baby. Now, today, it's a pediatrician's baby. Pediatricians actually have programs and they do it sensibly. I believe in the same way, advanced care planning is like a vaccination, which it is necessary for palliative care to own. Advanced care planning effectively is where death literacy is going to begin. Next slide. And again, as you've seen earlier, whenever this is done, then whoever does it, multiple copies have to be made. Everybody has to be informed. And ideally, surrogates, family doctor, on admission for any procedure, it should go everywhere. Next slide. I also tell my patients that you must show it to every doctor you consult. This is because you will find out if the doctor is willing to accept it and support you. And the doctor also has the responsibility of finding out their hospital's policy and will know your wishes. Now, this is important because we are right now in a in-between stage where things are evolving but have not yet been formalized. Next slide. And if you don't, so 3 famous nonagenarians, people in their 90s, passed on in 2018 and 1 in 2022. So that's 4. The 5th is at home, Jimmy Carter. So let me tell you this story. Next slide. Both Barbara and George Bush died in their own beds, surrounded by their family, literally in Darbar. You have pictures of them with dogs, cats, grandchildren, children, everyone is there. How did they manage their last days so smoothly? Because they took charge and their system worked for them. Next slide. And in India, well, Atal Bihari Vajpayee died on extracorporeal membrane oxygenation after about 10 or 15 days in the AIMS ICU. And Lata Mangeshkar, well, she was intubated. Those incomparable vocal cords were raped not once but twice. So my rule is that if you're an Indian VIP, you will be tortured before death. Now, it's important to understand that unlike cancer, where cancer makes all the decisions, old age, organ failure, neurological illnesses, in all of these, the prognosis is not that clear cut. And towards the end, we have the means now to keep the body alive indefinitely should we choose to do so. So decisions have to be made. Next slide. If anybody is interested, you're welcome to email me and I'll be happy to connect. My mobile number is also there. I'm there on WhatsApp. And I'll stop here. I think I'm just in time, 1 hour. We have enough time for the case and then to take questions. Thank you.
Thank you so much, sir, for that wonderful presentation. I would request anyone in the audience, if there is some queries which you would like to ask or comments you would like to make, you can either unmute yourself, raise your hand, or put it on the chat box. In the meanwhile, sir, yes, definitely, as on one side, when we are living, we try taking life into our own hands. As important it is to take death into our own hands, at least how it should happen as things move forward. Certainly more and more people need to start talking about this. Like you said, start talking about it is the starting point. And we
Yes.
have a diverse group over here. It is not just the doctor's duty. Of course it is, but many of us, in the healthcare system work at different levels, interface at different points in the patient's trajectory through illness. Sometimes in the home care setting, sometimes as a friend, sometimes as a neighbor, sometimes in a hospital. So anytime you come across seeing a family struggle through situations like this, it becomes your duty. In fact, I would use the word duty to inform them
Yes.
that there is something like this. You can make, I mean, there is, the decision is on the patient, whether how he wants to proceed. The family should not feel guilt-ridden if the patient chooses to do something. There can be a lot of unnecessary financial toxicity which can be avoided in many scenarios. I mean, this is all interlinked. So many things are interlinked into this one topic of advanced care planning, which is critical in any life limiting illness trajectory.
Thank you. Very well said. Okay, if there are no questions, let's go on to the case first and
Yes,
then
sir.
come
Yeah.
back.
Yes, sure, sir. So can we proceed with the case, please? Right. Arpita Ghosh. Yeah, please proceed.
Thank you, sir. Good afternoon, sir. Good afternoon, everyone. Am I hearable?
Yes,
Yeah,
yes,
yeah.
you're audible. Please carry on.
Uh, Good afternoon, sir. Good afternoon, everyone. I am Arpita Ghosh. I, I am going to make an presentation on advanced care planning. My patient is a male and he is 51 years old, and he has been diagnosed in cancer rectum, which also makes him liver, and he is a van driver. Medical history: he has pain in abdomen, bed sore, loose motion, swelling in limbs, that is filaria, insomnia, poor appetite, weight loss. He has taken radiation 35 times, and he has taken chemotherapy 10 times. He has urine problem and unconsciousness sometimes. He is taking following medicines: tablet tramadol 50 mg, tablet pan 40, tablet ondem 4 mg, tablet metrozil 400. Patient and his family are aware about diagnosis and prognosis, but don't aware about palliative care. Next slide, please. Okay, family overview. You can see that here is a diagram. In this diagram, patient is in the middle, and there are his family members also. So I am trying to put in rectangular shape those who are in rectangular shape, inside in rectangular shape, they are male, and those who are in an oval shape, they are female. And patient who has strong bonding and patient who have I have shown it in dark, who has strong bonding, and weak, who literally light, who has weak bonding with the patient. Next slide, please. This is an echo map. Patient and his family. Patient gets support from extended family, neighbors, health service, and relatively weak support from club, friends, religion. Next slide, please. Socio-economic overview. The patient was a van driver. He lives in a suburban area. He has his wife and 2 daughters. The elder daughter is married. The younger one is unmarried. He is worried about how he will arrange the marriage of the younger daughter. He has no income now and his financial condition is very poor. His wife works in a hosiery factory. She earns a little money. His son-in-law is a house painter. He helps his family. The patient brother-in-law also helps his family. He sometimes buys them groceries and other essential things. Psychological overview: the patient has poor mental health. Patient has mental anxiety and tension. He has tremendous pain in his abdomen, which adds to his agony. The bed sore at his back side doesn't let him sleep well. He becomes depressed as he thinks about his disease. He has a heavy financial burden, which also worries him. He feels that he is in a crisis and is worried and unhappy. Caregiver concern: caregivers see that the patient is suffering from insomnia and pain, so sometimes they become emotionally exhausted. They are financially weak and worried about how they will continue the treatment. The caregivers too are suffering from physical and mental stress. Total pain: physical pain. He has pain in his abdomen, bed sore at backside, rectum, insomnia, loose motion, and filaria. Psychological: he has depression, he cries sometimes, stress, worry about how will he arrange his younger daughter's marriage. Socioeconomic: poor financial background, financial crisis, but good relations with his wife, daughters, son-in-law, brother-in-law, and grandson, which gives him some solace and support. Spiritual: always thinking is how can he get well again. Hope for returning to work. Next slide, please. Points. How can the patient be given advanced care? How can we take care of the patient's advanced care as social workers? How can we help in reducing patients' physical and mental stress? How can we help in reducing the caregiver's physical and mental stress? Plan to action, home visits, keeping in touch with the caregivers.
Right,
Next.
Arpita. So where did you see this person? Can you give us a little brief about your interaction with this person and his family?
Yes, sir. I am a social worker. I am working in palliative care EIPC West Bengal, and I am working in Medical College Kolkata. So here we have a kiosk, and we work in palliative care kiosk. So here I met the patient.
Right. And were you able to do a home visit for this person?
Yes, I want to do with my team a
Right.
home visit.
So it's amazing that within a medical college setup, you are able to understand this much about a person. The family dynamics, the strengths in the society, and just the amount of suffering which is there physically as well as socially for this person. Looking at today's session about the advanced care planning and directive, can you tell me how you would want to guide this person? Suppose you did a home visit and this is all the information which you got. How would you like to guide this patient as well as family going forward? Is there some thoughts you would like to share? Others also, please feel free to share your thoughts as well. But Arpita ji, first you, after that, others.
Actually, I think that I have a conversation and I saw the patient. So I am keep touching with the patient or his family by phone. So I came to know that the patient is suffering so much pain, and sometimes he became unconscious, and he has so much actually pain. So I think that now he can't came to hospital. So if there will be a home visit, so and if they guide how they guide them that how will he or caregivers keep them at home at home, so it will be helpful, I think.
Right. So better guidance, you want to support the family to take care of this person at home itself.
Yes.
Is there anybody else who wants to comment? You've seen the situation this person is in. There are a lot of symptoms which he already has. Certainly, there is a call for a multidisciplinary approach over here, where we can obviously see that there is physical pain, uncontrolled physical pain, which calls for starting of certain medications, which will be taken a call on by the doctor. But Roop sir, if I may bring you in on the picture over here, it is seen that in one of the slides that he wishes to get back to work, and he hopes to become somewhat normal and get back to work. But looking at his clinical picture as a doctor, I don't feel so optimistic. Now, in this
Right.
situation, how is it that we can steer this person towards planning for his future? If you could give some thoughts on this, sir.
Yeah, the first part of the discussion will be, I agree. The first point is to manage the physical symptoms. A psychological care also will be required. Some of it will be counseling, some of it may be antidepressants. Spiritual care, it really depends on whoever is from the team that is visiting. And social support doesn't seem to be too bad. Of course, financial issues are there. But one thing we can be fairly sure about is that once the goals of care are aligned, and here it is that it's important for us to, although Arpita ji said that they are aware of the prognosis, but there is still perhaps an element of denial. I will get back to work. Is uh, well, potentially possible, but I guess with a bed sore and so on, that seems quite optimistic. So, goals of care need to be cleared here, and the patient and the family need to discuss their values about survival, functionality, and comfort. These are the three goals broad goals that we have to. At some point, since there is a mention that the patient is aware of prognosis, somewhere that question needs to come up about how he sees long-term survival. Then comes the question of whether they would like to prioritize return to function or comfort. Again, what is realistic, what is not, this needs to be clearly told. And often this is a part of the patient education that we are supposed to follow. So it's patient education together with goals of care. They both go together. Once that is done, depending on how the situation is, if it looks like the patient might be coming to hospital imminently, then we need to clarify that. What would they like to do if they run into a crisis? Would they want to take him to hospital? Would they want to manage him at home? It would also depend on the kind of support that the medical team is able to give at home if they offer to manage him at home. And here, I think advanced care planning, if we can sort out just that much, to go to hospital again or to manage at home, that is probably the most crucial thing that we need to sort out.
Right, sir. Certainly a lot of scope for an interdisciplinary team, Arpita ji, where you may have to discuss internally with your team first. That is along with the doctor and the nurse, yourself, on how to have a conversation with this person. Just like sir said, there is a certain mismatch between where he is right now and what his desires are, and somewhere we need to, probably the prognosis part of the disease needs to be explored further, the insights which they have and the family has, and certainly will be worthwhile. I mean, this may happen only in sessions, you may not be able to do it in one sitting, but this is something you'll have to gently take forward as a team together. Any other comments from the other participants? Any thoughts based on the approach on this for this person? Right.
Anybody wants to ask any question about advanced care planning or the advanced medical directives, or you're clear about?
Sure. Sir, we have a community medicine
Yeah, good,
specialist
good.
over here with us, Dr. Parth from
Yeah.
New Delhi, MAMC.
Okay,
He would like to ask something, sir.
good, good.
Hello, sir. Thank
Yes,
you.
Dr. Park.
Yes, sir. Thank you for the presentation, sir. I have
Welcome.
worked for a year in oncology and in emergency. And
Okay.
there has been a practice where there is a form called do not intubate, do not resuscitate form in the
Okay.
emergency, in the ICUs, and in the wards. Now, when last stage patient end of stage disease comes, end stage disease comes, and the patient is not in the condition to give any consent, usually the relatives are explained the prognosis, and the relatives sign that form, understanding the disease outcome and the financial toxicity, everything. I just want to ask
Yeah.
you, is that legal? Is that legally
So-
possible?
So, for one thing, the process of taking a DNAR, do not attempt resuscitation, that is perfectly legal and valid. I'm not sure what form your institution follows, but the ICMR form is as close to where it's been put out by the ICMR, which is the premier medical think tank of the government. So you can take it as being a government document. But even otherwise, sorry, yeah, but
Can the relatives consent for that?
of course, if the patient is not able to communicate, if the patient is not understanding, then you have to use the surrogates. That's understood. But if the patient is able to communicate, it is our responsibility to communicate directly with the patient.
Thank you, sir.
The other thing that perhaps may not be so relevant to people who are not physicians here, and that is to separate out do not intubate from do not attempt resuscitation. Too often we combine the two. But remember that you will have individuals, especially in dementia or people who are, or even say, for instance, with respiratory disease, where a short period of intubation and a time trial of ICU therapy for 3 days, 5 days, and the patient may actually have a reasonable quality of life after that, which is why do not attempt resuscitation, which means CPR, and do not intubate should ideally not be combined. Right?
Sir, I have a question for you, sir.
Bolo.
How is it? How do we tread that line where the patient may want one thing and the family may want another thing? I mean, of course, it is very clear for us when we say that autonomy is there, and as far as the person is not incapacitated, we will, the patient gets the say. But many a times, as a medical team, we may have to balance both sides, and in two different rooms, we may have two different kinds of directives
Conversations.
towards us. So how is it that, is there any personal experience which you can share on how you would have dealt with such a situation?
Ideally, if that happens, you need a palliative care team. But seriously speaking, these are palliative care skills. These are basic skills. We call this addressing collusion. And remember that your duty is always to the patient. So if the patient is compos mentis, can make up his mind, and this decision is fairly logical, clear cut, you agree with it, it's medical basis, then I think it is our duty to speak to the family and explain to them that that going against the patient's wishes may cause more trauma, more depression, and so on. And most often, patients' families come to this position out of a position of love. And in love, families want to protect, even against impossibilities. So you have to explain that to them. And I think that this is one of the basic skills that is taught in palliative care, how to reconcile these issues. It's not as though this cannot be reconciled. It almost always is, but it takes a bit of effort.
Right. I always remember this particular case which had happened in the previous hospital I was at, where the mother of a neurosurgeon was in the ICU, and she was having a type of a brain carcinoma with metastasis to different parts, and so she's sort of slipping into consciousness and unconsciousness. This is what was happening. Every time she would become conscious, she would point with the finger that she wants to go out. There is a BiPAP machine or something, or a CPAP machine over her continuously, and then she would point that she wants to move out. But her son was adamant that we had to keep her in for as much as possible. Being a doctor, as you know, it's always the most difficult category of people to deal with sometimes. So he was adamant that how things should move forward for her. But from her end, it seemed pretty clear. But even despite the palliative care team, the neuro team, everyone coming together, we were not able to convince the son. And she passed away in the ICU itself. But I was wondering that if there could have been something more we could have done, forcefully, if not by way of, understanding with the son. I was not sure of it. What do you think about that situation, sir?
I think one would be that whoever was the primary, ideally this was a discussion that should have been had much before she came into the ICU.
Right.
Obviously, the patient herself was reasonably clear about this. So she should not have been in the hospital. There should have been palliative care at home.
Right.
If she came to the hospital, then there should have been a clear understanding that she would not come into the ICU, and that comfort measures would be instituted. So I think that this what we talk about death literacy actually has to start off with the medical profession. The
Right.
medical profession is illiterate about death, literally illiterate. In
Yes,
fact,
sir.
sometimes you feel that patients seem to have a basic native intelligence which guides them through to what is right and what is wrong. We seem to have been taught all the wrong things.
Yes, sir. Sir, I think we lost you for the last 10 seconds.
See, in the medical profession,
Yes, sir.
as much as we need it in the rest of the world, we need it also in the medical profession. I think my
Absolutely right,
videos,
sir.
yeah,
Right.
I think I'm cutting out my video because
Sure,
that's,
sure, sir. Sure.
yeah, that's causing a problem, right? So we need more of this kind of educational material. We need more people to be aware of what the end of life is like.
Right, sir. Sir, any closing thoughts from your end, sir, based on this topic of today before we close?
So, well, let me put it this way. I have made my advanced medical directive, but I'm 64. I think all of us need to do it. Right?
Right, sir.
Yeah, and for those of you who are younger, at least start bringing this topic up at home, at the dining table. It has to be gently done. You can make sure that these documents are downloaded and kept around so that people can see them. We need to have them around everywhere.
Correct,
Like we have educational materials everywhere, we have to have these everywhere.
Right. Even at my home,
Okay.
sir, just like you said, I had this conversation once with my parents. My dad is a long-standing diabetic. Luckily, no complications. But then he was mentioning something about how he may want to pass, and then I was like, okay, yeah, let's make this into a proper, like the way it's supposed to be
Document.
done. We can do it that way. So
Yeah.
certainly, these are things which we need to look at about how the final act in our life of exiting, how it should be in our own hands and it should happen as gracefully and with as much dignity as possible.
Absolutely right. And the Pallium, the document that is there on the Pallium website is the correct document that we all need to follow.
Right, sir. Right. So for everyone, there is on the Pallium India website, there is a button called resources in which you can access these documents. So please feel free to explore this. If you have any questions later on, please feel free to reach out to us as well. We can direct these questions to Roop sir in the future. So with that, thank you so much, sir, for taking time out despite of being on a travel. Truly appreciate it.
You're
And
welcome.
such an important topic, though people are yet to realize the importance of it. Hopefully, before we all end up in some or the other form of sickness, if that happens, hopefully people do explore this for themselves and for those around them. So with that, have a good evening, everyone. Take care and stay safe.
Thank you. Thank you.
Bye.
Dr.
Bye.
for
Thank
a wonderful session.
Bye.
Thank you, Deep Doctor, for the facilitation. Thank you, everyone, for participating. Let's see in the next session. Thank you.
Thank you.
Okay. Bye.